As far as disclosures, I have no conflicts of interest or the disclosures that are relevant to the content of this presentation. In terms of our target audience, the overreaching goal of the PCSS-MAT is to make available the most effective medication-assisted treatments to serve patients in a variety of settings that include the primary care setting, psychiatric care, and pain management. As far as our educational objectives, we have three. We're going to compare and contrast the risks and benefits of medication-assisted treatment relative to medication-assisted withdrawal, otherwise known as detoxification, for the effective treatment of women who have opioid use disorder during both the pregnancy and the postpartum period. We're then going to compare and contrast the risks and benefits of methadone as well as buprenorphine to treat the mother during pregnancy and their relative efficacy and safety of the mother, the fetus, and the child. And then we'll also be identifying several factors that are associated with reducing neonatal abstinence syndrome among babies that have been prenatally exposed to medications such as methadone and buprenorphine. So in order to meet the objectives, we've crafted an outline. So basically, we're going to look at the historical context of opioid use among women in the United States, particularly among childbearing age. And then we'll look at the current scope of the problem in the U.S. We'll be defining what is neonatal abstinence syndrome, looking at treatment options for the mother as well as for the child, looking at agonist treatment options versus medication-assisted withdrawal, and looking at the different agonist options for the mother, including methadone, buprenorphine alone, the combination product of buprenorphine and naloxone, and then the opioid antagonist treatment, naltrexone, which we really do not have enough data yet, but I will mention it, and then finally, a summary. So it's important to give some caveats or some historical information. And one important point is that both methadone and buprenorphine have historically been labeled by the Food and Drug Administration as Category C. While those letter categories are no longer used, many physicians are familiar with these categories. And basically what it ended up saying was that some animal studies have shown adverse effects on the fetus, but there was a lack of adequate and well-controlled studies in humans. And so really, these medications could be used if the potential benefits outweigh the potential risks for pregnant women. As of May 2016, the FDA, the Food and Drug Administration, requires both methadone and buprenorphine, as well as other opioid agonists, to have a black box warning that warns of the risk of babies developing neonatal opioid withdrawal syndrome if they've been prenatally exposed to these opioid medications. Neonatal opioid withdrawal syndrome is more commonly known as neonatal abstinence syndrome, or NAS. Other important points to know as we go through this webinar is that we know that women can effectively be treated with methadone or buprenorphine, and the current labeling states for both of these medications that these medications can be used if the potential benefits outweighs the risks. It's also important to note that these medications should not be considered off-label use. These medications were approved by the FDA to treat opioid use disorders or opioid dependence, and pregnancy is a condition that happens, but still, first and foremost, the patient has an opioid use disorder for which these medications are effective. In terms of current important information, SAMHSA has just released clinical guidelines in February of 2018, and there were 5 main recommendations that they gave for terms of clinical recommendations. First, medication-assisted withdrawal, otherwise known as detoxification, is not recommended during pregnancy. They also stated, these clinical guidance, that both buprenorphine and methadone are the safest medications for managing opioid use disorder among pregnant women. They also gave the guidance that transitioning from methadone or buprenorphine, or from buprenorphine to methadone, is not recommended during pregnancy. Really, if you have a patient that is already stabilized on one medication, then we want, and they're having a good clinical response, we want to keep them on that medication. They recommended that breastfeeding is compatible with methadone and buprenorphine, and then finally that neonatal abstinence syndrome, that withdrawal that babies experience after delivery, should not be treated with a diluted tincture of opium, in part because of the other sort of substances that are in this diluted tincture of opium, including high rates of alcohol. This clinical guide, just for your reference, if you haven't seen it, I would highly encourage you to look at it. It has 16 fact sheets that are organized into several different sections from prenatal care to postnatal care. And so it makes it very user friendly. So you can pull out the fact sheet and just get the information that you need for a particular clinical question that you have. When we look at the historical context of opioid use in women, while we have our current opioid crisis in this country, we know that this is not the first time that it's happened. Opioid use was first recognized during the 1800s, and we know that the greatest proportion of individuals that were using opiates in the United States happened to be women, and they were most likely to be prescribed opiates from their physician. And opiates were used to treat things in women such as menstrual cramps or hysteria or even prenatal postpartum depression. The southern United States, similar to today, has among the highest and largest per capita of women that were using opiates. And then when we look at the legislation on how things changed with opiate use access, we see that the legislation in the turn of the century really focused around immigration, particularly Chinese immigration, and in our efforts in the Philippines to reduce the control or reduce the supply of opiates in the United States. And so for the first time, we started to see the media coming into play to sort of drive public policy. And we saw linkages between sensationalized drug use among women and then even sexuality to stimulate public outrage at drug use to facilitate the public wanting these policies to reduce opiate use access. And we certainly know that when we have women of childbearing age who are using any substance, including opiates, that we're going to have women that become pregnant, and those pregnancies are going to be prenatally exposed to that substance. And in this case, since we're talking about opiates, we can see that the first documented cases in our Western culture, that at least I can find, happened in 1875 and in Germany. In the United States, again, it was 1892, where we saw the first case reported of neonatal abstinence syndrome. And then in the 60s, we saw good friend and colleagues report on neonatal withdrawal signs. ZAINE-ALI reported the actual frequency of signs in the infants. And then in the 1970s, we had two important publications, including the Finnegan tool, for which is still the most commonly used tool to identify and treat neonatal abstinence syndrome. So what is neonatal abstinence syndrome? It's been characterized as alterations in the central nervous system, the autonomic nervous system, having gastrointestinal distress, and signs of respiratory distress. And so you can see on the slide examples of each of those things in the different categories to create the signs and constellation that define NAS. It's important to note that neonatal abstinence syndrome is distinct from fetal alcohol syndrome. We know we have a lot of data to show that babies that have fetal alcohol syndrome are at greater risk for having lifelong problems, whereas NAS, or neonatal abstinence syndrome, tends to be more treatable and appears to be more transient. That said, we know that having an NAS can set up the alterations of interaction between the caregiver and the child. And depending on how those interactions go, there can be either increased risk or less risk and more resiliency in terms of longer term effects. Going back to the historical context, we know that there have been different eras of opioid use. And we know that the first one, as I mentioned earlier, was in the 1800s. In the 40s and the 50s, New York saw large increases in teenage opioid use, and there was actually a very prominent book called The Road to H, where for the first time, young girls or teenagers were characterized that were using opiates as being sort of recalcitrant, very unloving, selfish, being promiscuous, being stigmatized as being harder to treat. And we also saw many more beds that were devoted to males than there were females. And the sort of stigmatizing of females has continued and really until the present day. There's sort of a myth that women are much more harder to treat than are men. In the 60s and the 70s, we saw the opioid use increase. In particular, it's been pointed to by our Vietnam veterans returning from that war. And then finally now, and most currently, we've had our most recent wave of opioids in this country in part with pain as the fifth vital sign, and increased pain medication access in a variety of legitimate ways. When we look at what the history is around pregnancy and opioid use disorders, but in the 1970s, particularly 1973, we saw papers that were coming out after methadone had been recommended and approved for the use of the treatment of for medication to treat opioid use disorders during pregnancy. And at that time, in the early 70s, there was a great concern about pregnant women, and so the FDA initially said that all women that were on methadone had to undergo a 21-day detoxification. There were a number of papers, and medical providers wrote to the FDA talking about the concerns around abruptly removing women on such a short detoxification from methadone. And then the FDA actually reversed that decision. And we've had almost 50 years of research to show that methadone is associated with very good outcomes. So we know it can reduce maternal craving, it can reduce the fetal exposure to bolus highs and withdrawals. And when we give this medication in the context of comprehensive care, which it was originally intended to be provided in, we know that we can reduce the health risks not only to the mom, but also to the fetus and to the neonate. Just a little bit more about the recent history of opioids in the United States. We had in the 1980s two really important reports that came out that really said that patients who had been receiving legitimate prescriptions for pain relief really had very low rates of leading to addiction with opiates. And then that also led to Purdue Pharma developing OxyContin, and there were also aggressive marketing changes in laws that allowed drug manufacturers to more directly market to doctors as well as to patients. In the mid-1990s, the pain is the fifth vital sign, of course, came up, and then we had the federal medical boards, the Federation of State Medical Boards talking about model guidelines for the use of controlled substances. And finally, in the early 2000s, we started to see some of the effects of those policy changes. And the FDA and the DEA started to reduce internet opioid sales, which had grown greatly. And then finally, we have a burgeoning of pain clinics opening across the country. The George Brothers is only one example of that, as you can see on the slide. And then unfortunately, from 2009 until the present day, we know that drug overdoses are surpassing motor vehicle accidents as a leading cause of injury death. More about the current scope of the problem. These are data from 2015, which is just really showing sort of the sheer number of individuals that are misusing prescription opiates, 12.5 million. The high rate of opiate deaths that we have there, you can see 33,091, and the economic cost, and this is probably an underestimate because it's 2013 data, of 78.5 billion. So clearly, the economic and the social toll of the opioid epidemic in the United States has just been incredibly profound. And it's also given us an opportunity to really make some important changes. These data come from Ted Cicero, and what we can see in these three different slides is that looking at the far left, you can see prescription opiates in the open circle and heroin in the closed squares. And you can see how the heroin has actually been reducing from the 1960s to the 2010s, although there's a little uptick in the last 10 years. And then you can see how the prescription opiates have started to climb, and then there's a downward tick as heroin has been upticking. It's most traditionally thought of that males are the most common users of opiates. And you can see here this closing of the gender gap. It was very wide in the 1960s. And in the 2010s, we actually saw a surpassing of women compared to men. And then finally, it's also, opiates have been traditionally seen as a non-white issue. And we can see here the large number of proportion of white individuals who are using opiates compared to non-white. And that's not to say that that is, we still have many minority populations that definitely need treatment. When we look just at the most recent data from 2015 and 2016, we can see the annual number and age-adjusted rate of overdose deaths in the United States. And if you focus on males in the blue and the red bars respectively, you can see that across all of those bars, compared to females in the green and the purple respectively, that for all of those bars, males have higher overdose deaths compared to women. But you can see that when we look at the prescription bars, that tends to be a smaller gap than we have with all of the opiates. So with women, there are a few things that we know about them currently. We know that compared to men, women are more likely to be reporting chronic pain. It doesn't mean that they're more likely to have it, they're just more likely to report it. We know that women compared to men are more likely to be prescribed prescription pain relievers and in higher doses and for longer periods of time. We know that women tend to have what we call a telescope effect, which is that sort of shortened duration between their first opiate use and their seeking help for their opioid use disorder. And we see that actually across many different substances, alcohol, cocaine, the variety of different substances, women tend to have this telescoping effect. And of great concern is that women have been found to be less likely to receive naloxone for an overdose than their male counterparts. And that is something actually that we've been working to really address, helping to train first responders so that they know to look not just for injection paraphernalia, but really for more subtle signs of the factors that can indicate an overdose by opiates for which naloxone would be an appropriate response. So when we compare women and men some more, we know that women on average tend to experience greater impairments in all aspects of their life when they are using substances compared to men. That be it in terms of employment, in terms of social roles and responsibility, they tend to have greater psychiatric co-occurring disorders and more medical problems than men. We know that women certainly, by their sheer biology, can be more subjected to sexual risk factors and injection practices based on the cultural norms in the drug using community, and that we also know that very few women who actually need treatment receive it every year. So these data show you the prevalence of opioid use disorders during delivery. And what we can see is that while in the United States, we know when we have a greater prevalence of individuals or the general population using opiates, pregnant women are not immune. And so we can see here that the rates of overall women who are pregnant delivering with an opiate-exposed delivery have been growing. You can see that in that light blue star, the overall. And then we can also see in terms of the ages, it's that 20 to 34-year-old age in the green with the little triangles that you can see has tended to go up the most. So I think it's important when we talk about substance use during pregnancy that we don't forget the other types of substances that women are using and then become pregnant. And so these data are from 2015, the most recent National Survey on Drug Use and Health data that we have, looking at past month use. And you can see in the comparing non-pregnant bars to pregnant bars that for the alcohol and tobacco, that those are the most common substances that are used by both non-pregnant and pregnant women. Interestingly, in the pregnant women, it tends to be that we see a greater reduction in alcohol use in the orange bars than we do tobacco. So tobacco tends to be the most common substance used by pregnant women. We also know that these are data from 2012 among women of childbearing age, that we can see these are opioid misuse data among females that are admitted for treatment. And we can see that pregnant women are actually more likely, or a higher proportion, are likely to receive treatment than their non-pregnant counterparts. And I think that in part is to do with the federal laws and regulations that we have giving priority status to women who are pregnant. Pregnancy is a wonderful and unique opportunity for women to think about behavioral change. However, it also can be a double-edged sword because I think there's a tendency for providers and family and friends to think that just because a woman is pregnant, she's going to magically have greater motivation to change her behavior. And sometimes it leads to greater shame, guilt, and stigma and a fear of seeking treatment. And unfortunately, mothers who have substance use disorders have a greater mortality rate than women of a similar age without such a substance use disorder. We also know that prenatal care, even if a woman does not stop using substances, can have a positive impact on her and her birth outcomes. We really need to do more in this country to be able to help women access prenatal care, because we know that there are a number of barriers that women that have substance use disorders face, including a huge fear of having their child taken away from them at birth. Um, and we know that we really need to have a much more therapeutic approach in terms of being able to really help the child. We absolutely have to help mom have greater well being. So these data were published in JAMA. First author was Stephen Patrick. And these data were the first national data that we had that really looked at the weighted estimates of rates of maternal opiate use in hospital births that showed the increasing use of opiates among pregnant women. So you can see there in 2000 that only 1.2 per thousand births had an opiate use versus in 2009 it was 5.63. There are more recent data that continue to show the escalation in rates continuing to go up. But these data were really important in terms of turning on sort of the faucet around the national conversation around neonatal abstinence syndrome, because when you have greater opiate exposed pregnancies, you also have a risk of having more rates of NAS, and that's what we can see in that other graph there. These are the current data that we have, which shows that every 15 minutes a baby is born with a diagnosis of a neonatal abstinence syndrome. We know that costs have also grown. It tends to be that babies that are covered by Medicaid the incidence has been growing greater than when all babies in the United States are compared. And the really wonderful thing about this fact, this graphic, is that now we see that moms are actually part of the discussion, needing more resources and compassionate care, not just before and during, but also after pregnancy. And when we talk about neonatal abstinence syndrome, if you remember nothing else from this webinar, I hope you will remember this slide, because newborns by definition cannot be born addicted. They don't have enough life course to meet the definition of addiction, which is use despite negative adverse physical relationship consequences, among other things. We know that babies that are born that are abruptly discontinued from that opiate exposure can be born physically dependent on that opiate and can have a withdrawal, but it is not the same as addiction. And it's also important to be very careful when you're looking at the literature to be very careful to delineate what is a neonatal withdrawal, and thinking about our ICD-9 and ICD-10 codes, which those are the data that are being published now, and that not all of the ICD-10 and ICD-9 codes really are neonatal abstinence syndrome, and not all neonatal abstinence syndrome equals an opiate use. And I'll show you the next slide in a minute that'll show that. But it's really important to also remember that neonatal abstinence syndrome is not a diagnosis for mom that she has an opiate use disorder. And so this is a slide I had alluded to. So we know that certainly heroin, methadone, buprenorphine, and other opiates are related to having a neonatal abstinence syndrome. You can see here the onset, the frequency, and the duration for the different types of opiate substances. So that's something that's expected. But I think it's also important to show that that last part of the table for the non-opiates, that we see just for even selective serotonin reuptake inhibitors, that it's debatable whether or not it's the actual toxicity of the drug that is causing the signs and symptoms of baby altered behavior that has been attributed to the neonatal abstinence syndrome, or if it's an actual withdrawal from that SSRI. But you can still see here that onset is happening 1 to 2 days after birth, and that 20 to 30% of babies that are exposed to SSRIs in utero are being identified as having an NAS. And also of note in this slide are the inhalants that also is expressed 24 to 48 hours after birth, and almost half of babies exposed to inhalants have been diagnosed with having a neonatal abstinence syndrome. So the important point is NAS can be a variety of different substances, and it's not just opiates. So we can't just make that assumption. We also know when we're looking at the NAS literature that there are a variety of factors that can contribute to how long an NAS lasts and how severe it is determined to be. We know that genetics can increase the length of stay, or has been associated with longer lengths of stay. We know that tobacco use, benzodiazepine use, and as we saw in the previous slide, SSRI use can also lead to longer lengths of stay, more medication use to treat neonatal abstinence syndrome. And there's things of a note that hospitals can do to actually reduce the length of hospital stay, then the severity, the overall generalized attribution of severity to NAS. And that includes looking at, are babies treated in a neonatal intensive care unit? Babies that tend to be treated with their mother have less, there are fewer babies that actually need medication to treat their NAS. The choice of tools to examine and assess NAS can make a difference, as is supporting breastfeeding, and then keeping that mom and baby together can all, as a constellation, help reduce the amount of medications babies are exposed to and the time that they stay in the hospital. There are a couple of predictors that have been noted in the literature in terms of receipt of NAS treatment. Having a higher birth weight can lead to a higher risk for having medication to treat NAS, as can more nicotine use, and I'll show you specific data on that later. There's often an over-reliance on urine testing in our field, and I think it's really important to note that just because a baby has a positive urine test for a specific substance, or a mother has a positive urine test for a specific substance, that this does not determine parenting. All it tells you is that there has been recent use of a substance. And really having a substance use disorder, if that is found in the mom, should really only be one factor in determining overall safety for children to go home with mom. And if urine toxicology or any other type of biological matrix is used to look for substances that have been used during pregnancy, there needs to be confirmatory testing and not just rely on quick dipstick methods or non-confirmed quick tests to make such life-changing decisions for mother and child. It is also important to remind you that patient consent, maternal consent, is needed before specimens can be collected from the mother. Maternal consent is not needed for neonatal collection. It's important for you to know about changes in federal policy that have happened. So the CAPTA, which is the Child Abuse Prevention and Treatment Act, has been updated recently when the Comprehensive Addiction and Recovery Act was passed in 2016. And what CAPTA really does is it removed the word illegal from the definition and also put much more emphasis on a plan of safe care. And if you see that last part of red on the slide, you can see that the development and implementation by states of monitoring systems that regard the implementation of these plans of safe care became very important. And all states are required, if they're receiving money for child protective services, they need to be reporting very specific data to the federal government around plans of safe care and how they're being, who's receiving them and how they're being implemented. And so I would encourage you to know what your plan, how your state has been responding to this new federal policy. We often think that any woman that has a positive urine test for a substance has a severe substance use disorder, when in fact, we know that there's a wide range of substance morbidity or severity, right? It can be from no use to more just occasional mild issues all the way to the severe use. And so I think it's important to really think about what type of treatment is really needed in order to best respond to the level or severity of a substance use that a woman has. And so that brings me to a case study that I'm going to ask you to think about as we walk through the rest of this webinar together. So how would you approach this woman who's a 24-year-old woman who's coming to you for opioid use disorder treatment? She's now 13 weeks pregnant, so she's in her first trimester. She's never been pregnant before, and she's been using opiates continuously for 7 years and just started injecting. What are the things that you would want to know, and how would you respond to her to manage this patient? And I would encourage you to spend 2 minutes and write down a few things what are the sort of first things, how would you address it, what would you do, and then see if your answers will be changed or augmented in some way by the end of the webinar. And so as you're thinking about how you're going to respond to this patient, thinking about it's not just the substance use disorder for which she needs treatment, that there are a whole range of possible issues that are facing pregnant women who come into treatment and their subsequent children. So thinking about what are the risks and resiliencies that moms bring to treatment in terms of, limited parenting exposure, the psychiatric issues. There's also a dad that's involved, and thinking about history of neglect and abuse for the entire dyad, and then thinking too about children's temperament, their own medical issues, and neurobehavioral and the developmental age of the child. All of these different things that you see on the slide can be important factors that can influence outcomes for both mother and child, independent or related to the substance that's being used. And as we think about that case, we need to remember that not all opioid exposure is the same, that we have a whole range of different types of patient scenarios. So you can have women that have an untreated opioid use disorder, and so you can see there in terms of heroin. You also have patients that have that are being treated with a methadone or a buprenorphine, and obviously no medication to treat opioid use disorder during pregnancy is without a risk-benefit ratio. And that's true for opiates, it's true for any medication that we give to a pregnant woman. But we need to really balance that against what happens to not treating it at all. Where will she be and what will happen to her and her child? And then we have another scenario, and there are a myriad of different scenarios, but this is just sort of a third common patient situation, is where you have women that have been receiving opiates for pain management. They don't have an opioid use disorder. And so again, thinking about what are the relative risks and benefits of maintaining that patient on her opiate to treat her pain. What happens if we don't treat her pain? Women, I can tell you, are incredibly scared of coming to treatment. Their fear of going to jail for their drug use, they have fear of losing their children once the child is delivered. They have a tremendous amount of shame and fear of stigma. They have a lot of guilt. They have remorse. Many of the women, at least that I work with at Horizons, have incredibly limited resources. And so they really need help and support for how are they going to get to treatment every day? Who is going to take care of their child if there's an all-day intensive outpatient program or even more intensive, for example, residential program where their children can't come? So in thinking about those barriers, that fear, that discrimination, the prejudice that women face, let's think about a new clinical question. And this would be a woman who's 32 years old, 4 months pregnant, has lost custody of her 3-year-old, clearly has a number of other medical issues going on, and she's denying her drug use. How do you respond to her? What do you need to say to her to make her feel more comfortable and to trust you to be able to provide the best possible care for her? Now we're going to turn to talking about medication-assisted treatment versus medication-assisted withdrawal, otherwise known as detoxification. So it was the WHO, the World Health Guidelines in 2014, that was the first guidelines that I'm aware of that really talked about using opioid medication in the forms of methadone or buprenorphine as a first line approach over some kind of detoxification for women during pregnancy. So we know that using detoxification for non-pregnant patients hasn't really been found successful. There's a high attrition in treatment and a rapid return to illicit opioid use. So it's curious to think why we would want to try and use this ineffective approach for non-pregnant patients with pregnant patients. We know that medication has facilitated retention of patients and has reduced substance use compared to no medication or no treatment. And we also recognize, certainly, as we've talked about earlier, the risk-benefit ratio and neonatal abstinence syndrome is a risk, and we also know that it is a treatable condition. These are data that are a retrospective record review that are still the best data that I can find that really looks at a head-to-head comparison of various types of detoxification protocols versus a methadone maintenance protocol. And so what we see here in the top graph is that patients that had only received medication-assisted withdrawal in the light blue, which was 3 days, or the green, which is 7 days, that we see a high rates of lost treatment or very low rates of being retained in treatment. Whereas if women were receiving methadone maintenance, that we have see much higher days of retained in treatment. And then when we looked at urine positive drug screens at delivery, we can again see higher rates of urines that are positive in the medication-assisted withdrawal groups compared to the methadone maintained groups. So what that tells us is that methadone maintenance is a good way to retain patients in treatment and also to reduce drug use. There's been a lot of attention looking at medication-assisted withdrawal. This is one of the most recent studies we have by Bell et al. There were 4 different groups of patients that received detoxification. Group 1 was in an inpatient setting, and then other groups were outpatient setting with various forms of more support in group 2, much less support in group 3, and then a slower wean in group 4. And one of the reasons it was said that the study was done was to look at avoidance of neonatal abstinence syndrome, whereas if you look down below, in terms of pregnancy outcomes, the rate of NAS, all groups still had some proportion of babies that had neonatal abstinence syndrome, and in some cases it was even 70%. So I think we need to be very careful when we think about why we're using detoxification or medication-assisted withdrawal when it really isn't avoiding the incidence of NAS. These data did show that, which is consistent with past literature, that it is possible to withdraw women without obstetric complication during pregnancy, and that it did have lower rates of relapse than some of the other studies that we've seen. But we have, unfortunately, we don't have much information about women who were lost to follow-up to know what their longer-term outcomes look like. And so, with the data that we have collapsing across a variety of different studies, old as well as new, we know that relapse remains a very significant clinical concern for detoxification during pregnancy. You can see the range there from 17 to 96%. We really don't have data to support that this is a way to reduce neonatal abstinence syndrome once the baby's born, and that this can actually increase the risk of maternal relapse and poor treatment engagement, which we know is not going to be helpful to improve either mother or child outcomes. So really we need to be thinking about how we can better treat this maternal chronic disease and not use such an acute approach, but really look at more optimal long-term approaches. The SAMHSA guidance document also recommended against using medication-assisted withdrawal, and you can see there that they're advising that patients need to be advised that such withdrawal can increase the risk of relapse and doesn't have much fetal or maternal benefit. I want to give a shout out to Tricia Wright, who has been really a leader in looking at maternal mortality in this field. And as you can see here, these are data that show over the last 14 years that we've got an increasing rate of maternal mortality. While we've done a good job with reducing neonatal mortality, maternal mortality is going up. And looking more closely at this data, we know that it can be attributed to a variety of factors, including suicide and including overdose. And so we really need to be taking a much closer look at what we're doing for our women postpartum. So now let's take a closer look at the different medication options that we have. In terms of methadone and buprenorphine, there are actually very similar advantages and disadvantages for the pregnant patient. We know that methadone, historically and in the collective literature, tends to be much better at retaining patients in treatment than does buprenorphine. And then we also know that buprenorphine has a lower risk of overdose and fewer drug interactions, and also has the advantage of being able to be given in an office-based treatment, which can be a double-edged sword if patients need a greater structure that is helpful in a place where methadone is provided. In terms of disadvantages, every medication has a disadvantage. You can see those here on the slide, and certainly one of methadone's disadvantages has been a longer neonatal abstinence syndrome compared to buprenorphine. In terms of buprenorphine disadvantages, the induction can be a bit more tricky, and there can also be a greater risk of diversion because we've got more access because of the way it's prescribed in an office-based setting. The next couple of slides just show an example of an outpatient induction. It is not a purely home induction, but it is an induction that we've used at UNC Horizons, where we bring women in, we provide them with a CALS, they give us that the clinical opioid withdrawal score, and then we provide them with their first medication, wait a couple of hours, and then we'll be reassessing the CALS score over again. They can go home. They end up taking their next dose of medication at home, and then they're having good clinical contact with our nursing staff over the next couple of days to adjust their doses. And you can just see that on days 1 through 4 with the different dose scenarios and what's happening and how we have a flexible way of responding to our patients. And we've had good clinical responses to this type of induction. In terms of primary outcomes for what gave us the data in order to feel more comfortable to prescribe buprenorphine to pregnant women, the mother study that was published in 2010 is one such study where we were able to do a double-blind comparison of methadone and buprenorphine. It was an efficacy study, and what we showed was that the proportions of babies that were treated for neonatal abstinence syndrome were not different between methadone and buprenorphine. But what was different is when a baby had a neonatal abstinence syndrome and was buprenorphine exposed, they required much less medication to treat that neonatal abstinence syndrome and stayed in the hospital for a significant shorter period of time. That said, both medications in the context of comprehensive care produce very similar other treatment and delivery outcomes. While that was a very well-controlled study with very particular questions to be answered, we now have a meta-analysis of the whole variety of other studies that we have comparing methadone and buprenorphine, and you can see those outcomes summarized here, where buprenorphine-exposed neonates in this meta-analysis were shown to have higher mean gestational age, greater birth weight, longer length, and greater head circumference at birth compared to their methadone counterparts. That said, methadone and buprenorphine are both efficacious medications, and now that we have two medications, we have more ability to be able to match patient and medication. Another plaguing clinical issue in the field has been about the issue of the combination product and what is that effect on pregnancy, because the main medication that has been used has been the mono product of buprenorphine alone. And so there are a number of papers that have looked at comparing the combination product to either methadone or buprenorphine, and pretty much the take-home message is that these outcomes tend to be very similar between the different types of, between the two buprenorphine formulations. These data are among my very favorite data that we've ever published, and really what this shows is that combining methadone and buprenorphine together from the mother study, the looking at just categorizing across the rates of self-reported rates of smoking, what we can see is it's really the severity of smoking that are driving a lot of the outcomes. So we can see for all 4 outcomes that are looked at, there is a dose relationship between better birth outcomes with less to no smoking compared to those that have average or greater than average smoking. Another issue that has been very concerning to the field is what happens to the long-term outcomes of children that have been prenatally exposed to buprenorphine or methadone. And these data are the most recent data that we have from, again, the mother study, so that was blinded assessments of children. And what we saw was really no pattern of differences in physical or behavioral development between those babies that were prenatally exposed to methadone or buprenorphine or those that have been treated or not treated for a neonatal abstinence syndrome. Other clinical issues to touch on in this field include pain management, and we know that we should not be interrupting the methadone or buprenorphine treatment that patients receive. We should not be taking them off of their medication before they deliver, and that every patient needs an individual pain management plan before she delivers. The SAMHSA guidelines have given a nice conversation about what type of pain medications to use, and I would just highlight that we want to not be giving large numbers of opiate pills to patients that are postpartum, particularly not vaginal postpartum patients without other types of complications, and that we want to be avoiding those partial agonists that can throw women into acute opiate withdrawal. And you can see those on the slide. In terms of breastfeeding, breastfeeding we know in and of itself has great advantage to both mother and child in terms of the most complete nutrition for a child. We also know that the amounts of medication from methadone or monobuprenorphine are incredibly low that are getting into the infant milk, and then even with buprenorphine, because it's so poorly bioavailable, the infant's getting even less of that medication. So the most recent guidelines suggest that both medications are compatible with breastfeeding in stabilized women. In terms of the combination product, we don't really have data on this product yet. So the product label says we need to exercise caution, but we really need to consider sort of those developmental and health benefits of breastfeeding along with mom's need for the medication. In terms of naltrexone, we have very little data on this. We know it's an antagonist. It can reduce opioid craving, but the expert panel from SAMHSA couldn't agree whether or not it should be recommended. So again, thinking about that risk-benefit ratio for the individualized patient will be important. Some of the issues to think about with naltrexone include induction. If there's a woman that's not already maintained on her naltrexone, this is certainly going to be a challenge and could create great fetal stress. Thinking about pain relief options if when mom goes to deliver and postpartum can be an issue. And then there are issues around breastfeeding in terms of the possibility of reduced milk production. So we really need a randomized or some kind of prospective trial looking at the relative safety and efficacy of naltrexone. We know that rates of naltrexone are increasing in this country as yet another option for how to address opioid use disorder. So we really need those data sooner rather than later. Whatever conversation that you're having with women around an opioid use disorder medication to treat them, we need to be making sure that our documentation is very clear and very rigorous, documenting the conversations that you have with women around the risks and benefits, documenting how you're going to address their pain relief during labor, delivery, and postpartum, what breastfeeding recommendations you have, and where the woman is going to deliver in the hospital, what those protocols are for her, and what the protocols are around neonatal abstinence syndrome. There are huge variations in what's happening in this country, and she really needs a compassionate and informed response. I really wanted to make sure that we talked about screening versus urine testing. There seems to be a lot of confusion in both practice as well as the literature right now. And so screening for substance use really should be a verbal or written or computer questioning about patient history. Whereas urine testing is only one piece of that information as a screening, but urine drug testing is distinct from screening for substance use. We know that such urine drug testing really can't replace screening and a conversation with the patient. And so we need to be very careful, too, about what type of drug testing that we are doing. We need to be getting consent, and we need to be knowing, recognizing, and acknowledging the limitations of both screening as well as testing. So let's talk a little bit about what kind of, should all pregnant patients who have an opioid use disorder be considered high risk? And the answer is no, that we really need to be thinking about each patient individually, and just because they have a substance use disorder, particularly an opiate use disorder, doesn't necessarily qualify them for being high risk. We need to be looking at all of the issues that are happening with the patient to determine if they're high risk. There's also a question commonly about, well, once the mom gets through her treatment and she's delivered her baby, should we then be tapering her off of her medication? And that needs to be a very careful, documented conversation and really thinking about what is best for mom and baby. And we know that if a mom is stable on her medication, that the likelihood of her continuing to have stable outcomes improves. So before you consider tapering off her medication, you really need to have a very good safety plan if it's really what she wants to do. She needs to be thinking about how is she going to maintain that social environment, that stability at home, what kind of partner support does she have, what kind of support does she have in her community. She needs that safety plan to be in place before that tapering starts. And what's going to happen to her and her child if she does return to substance use. So, and if that decision is made to discontinue, the slower the better, to ensure that there's an opportunity to talk about the role that medication is playing in her life at each stage, and that there can be a resumption of or an increase in dose if that's what she needs to make sure that she's continuing to be stable. Another important piece of that plan is giving every patient that is prescribed an opioid agonist naloxone that she knows how to provide, and that her caregivers also know how to provide. And I think all of this, everything that we do in terms of treatment, needs to be grounded in a recovery-oriented system of care that includes supporting not only treatment, but those dimensions of recovery that help keep patients well, including women in the postpartum period. So, what does her overall health look like, her physical health from head to toe? What does her home look like? What do we need to do to help get her the safe place to live and help herself get the safe place she needs to live? What is that purpose that she's living for? How does she feel connected and grounded to not only herself, but others and community? The opposite of addiction really is connection. And so maintaining those healthy systems of connection is an important part of that recovery oriented system of care. So coming full circle to where we started, thinking about that patient that came to you in the beginning where she's 24, the first trimester, first pregnancy, and using opiates for 7 years, how have your answers changed in how you would manage this patient since the start of the presentation? I would encourage you to take 1 or 2 minutes to jot a few things down. So just to summarize, we know that opioid use disorder is growing among women, and pregnancy certainly is not a protective factor for this. We know that it's a great risk to have an untreated opiate use disorder during pregnancy, for not only for the woman, but also for the fetus and her child. We know that NAS is certainly a serious condition. It's gotten a tremendous amount of attention, but it can also be treatable. And we really need to be working with mom and baby to sort of build up those resiliency factors and reduce the risk factors. There are a lot of different factors that healthcare providers can do to help reduce length of stay and amounts of medication that are given to babies needlessly to treat NAS. At the same time, our whole goal shouldn't be to avoid all medication for babies that have NAS for which it's truly needed. And then finally, medication-assisted withdrawal, otherwise known as detoxification. We just don't have the evidence to recommend it as a treatment for pregnant women. We know that both methadone and buprenorphine are FDA products. There's a great discussion around pregnancy and related issues in those product inserts. I would encourage you to read them. We know that they're the safest medications that we have right now for treating opioid use disorder during pregnancy. We know that induction doesn't really have to be any more complicated during pregnancy than it does in non-pregnant periods. And certainly breastfeeding is recommended for women who are stable on their medication. Like any medication, both methadone and buprenorphine have advantages and disadvantages to each other, and we really need a tailored approach and a good conversation that's documented about which medication is best for what type of woman. We need to know more about naltrexone, and we need to have more information around breast milk, and really, those predictive, like it would be great to have a predictive algorithm to know which type of patient is going to respond best to which type of medication. And we have a whole host of references. And I will end with just saying something about the PCSS mentoring program that's designed to offer mentoring assistance to those in need of one-on-one interaction with colleagues to address those clinical questions that you might have. You certainly have the option of requesting a mentor from the mentoring directory, and I know that the staff would be happy to pair you with somebody. And to find out information, I would encourage you to visit their website. There is a discussion forum that can be really helpful for asking a colleague if you have any types of different questions that that can be answered by a whole variety of fantastic clinical experts. And with that, I will thank you for your time and attention